Headphones or no headphones, Dr. Kyle Greenway shows us how to set the stage for ketamine-assisted therapy, from the blankets to the playlist. Welcome to the Carlat Psychiatry podcast, keeping psychiatry honest since 2003.
I'm Chris Hagan, the editor-in-chief of the Carlat Psychiatry Report.
And I'm Kelly Newsom, a psychiatric NP and a dedicated reader of every issue.
This is part 2 of our interview with Dr. Kyle Greenway on how to do ketamine-assisted therapy in practice. So if you haven't listened to part 1, start there and rewind to last Monday. These are techniques that I think people are going to find useful whether they prescribe and deliver ketamine directly, or if they just have patients who are going to receive ketamine, because they're basically things about how to set up the treatment in the patient's mind, how to help the patient get the most out of it, and how to help them change their lives while they're going through ketamine therapy. Can you walk us through the Montreal Model?
One of the lessons that we learned early on working with ketamine that I've alluded to is that I don't think it's the end solution to treatment-resistant depression. I think it's best conceived of as a catalyst. And so the first thing that we do with our patients is to set goals after we've confirmed diagnoses and made sure the fit is going to be good, is to set goals for the treatment process with a line that is something like, if we imagine that your symptoms were significantly improved in 1 or 2 or 3 months from now, what are the sort of activities we would see you doing to keep yourself well? And that question is really key because sometimes people with treatment-resistant depression are so focused on medications and their symptoms that they forget about the basics, or they deprioritize the basics, like having a routine, sleep hygiene practices, getting out of the house and exercising, diet, all those things that we know are really responsible for maintaining mental health in all humans. Goal setting is very front and center in our model, and we try to come up with at least 3 SMART goals, specific, measurable, actionable, realistic, with a time. That will often be as simple as, okay, I'm going to get out of bed every day at the same time and take a shower. Because we've had many, many patients. And, I have to say, it's only because of this work that I even think to ask these questions now to patients with depression that I meet. But we've met many, many patients who basically live in their beds. I don't think there's any drug or any psychedelic or ketamine or anything that will keep somebody free of depression if that's the sort of way they spend their time. So that rationale is how we ended up really focusing on behavior when we start working with a patient. Another thing we do is we review medications, and a little bit as we were talking about with benzodiazepines, we decide whether we're going to make rational changes, even difficult changes, right before the ketamine process begins, knowing that the ketamine process is something that really inspires hope and will often help patients tough through really challenging medication changes like stopping benzodiazepines.
Were there other medication changes that you focus on making, like getting rid of useless antidepressants or something that you do?
I mean, basically, I think as we all try to be evidence-based, sometimes with a case of treatment-resistant depression, we find ourselves with 6 or 7 medications in combination that don't make a lot of sense in hindsight.
Just getting rid of irrational polypharmacy, stuff they didn't have a clear response to, try to clear the deck. That makes sense.
Exactly. And in some ways, the process, we do it mostly as an outpatient, but it resembles a little bit of what we might do when somebody is admitted, of probably washing out medications pretty quickly, having a little bit of a restart and thinking about their care.
What about someone who's started amphetamine 20 years ago for depression and they're just taking that medium dose on and on? What would you do with that one?
Yeah, that's the kind of thing that I would be thrilled to at least try to stop.
So benzos, you have a real rationale to stop. The others, it's just kind of good practice to try to stop.
Exactly. I guess what I'm trying to say is kind of a core thinking in our model is, and this is based on the population that this was developed with, a lot of people with treatment-resistant depression have years, sometimes decades, of this kind of slow-moving machine of trying different medications. And meanwhile, even though the intentions are good of their care providers, often we end up in a situation of polypharmacy, of kind of irrational medication combinations, of people that are a bit psychiatrized in that they've forgotten that a lot of what will keep them well is in their hands regarding their habits and their behaviors and their relationships. et cetera. And it's in part because there's not really a trajectory to 5, 10, or 20 years of just trying different treatments. And so we try to look at the ketamine process for us as like, okay, we have really one shot to really know if this is going to be something that can have a profound benefit for you. So how do we make the most out of it? What are the things we're going to do before we start the ketamine treatments? And what are the things we're going to plan on doing during and after to really give you every chance possible to break the cycle of TRD?
That's great. So clear the plate, get a SMART goal. What are the other steps?
Yeah, so we always ask people to start in psychotherapy. In Canada, we are often able to find somebody available to give psychotherapy in the public system. This is based on a rationale that, and other people who worked a lot with TRD populations have kind of come to similar conclusions, that there are so many psychological issues involved in treatment-resistant depression. It's an important thing to at least have some kind of evidence-based therapy in terms of the treatment approach. And many patients have tried 10 medications or 20 medications and never really had a good shot at psychotherapy. So we ask people to start in psychotherapy. We help organize it before the ketamine treatment process is going to begin. And the other reason why we have that is because many of our patients are very isolated. And the ketamine process is guaranteed to generate psychological material, for better or worse. And it ranges from, wow, I feel better and I don't know how to make sense of the last 10 years of my life. People have said, for example, I feel so much better that I wonder now if I was faking it for 10 years. People are sometimes really disappointed that the partial benefits or the lack of benefits that ketamine has delivered just really hasn't been that significant. And that also is a place where psychotherapists can really help, prevent something like hopelessness or suicidality from showing up. And, the other thing is, in our model, of course, we deliver our ketamine treatments in a semi-psychedelic way. And that generates material, be it emotional, autobiographical, spiritual, that, again, people often need a little extra support to kind of sift through and make sense of.
So I take it you have a preparatory session?
Yeah, you're quite right. So our evaluations are usually 2 to 3, evaluation/preparation are 2 to 3 sessions. And the first one is really about diagnosis and getting a snapshot of like a day in the life. I really, really go hour by hour with my patients about trying to understand all the different ways they're spending their time. And not just leaving it at the standard, I do nothing with my day. Because my doing nothing and you're doing nothing and somebody else is doing nothing might be totally different. Then the second evaluation or visit for us is really about treatment expectations, coming up with these goals, looking at the medications and doing sort of this reset of treatment plans. And then usually the third visit is when we get into a little bit more of the psychological issues around ketamine. And we'll do things like, for example, do a little bit of body scanning or meditation exercises to see and try and cultivate a sense of, curiosity, openness to one's experience.
And all of these 3 are before you receive ketamine?
Absolutely, yeah. And usually for some patients, they're staggered over 3 months or 6 months, because I generally won't schedule the first dose of ketamine until I feel like there's a really strong collaboration. And the only way I really can judge if there's collaboration is that we set some goals and we've seen some progress on them. And I know it's not everyone's practice, and I know many private clinics will start treatments right away. But I actually think that's doing a disservice to people, because sometimes people are not ready. Sometimes the alliance is actually much poorer than we think it is superficially. And, the whole ketamine process in my mind is just so intense and requires really a lot of trust that I don't rush into the first dose.
So I imagine during those 6 months, you're not just having 3 sessions, or you're having a lot of sessions and waiting for the alliance to develop.
You know what? It varies. It's usually not that many sessions, but it might be a handful of phone calls. So, for example, on first session, we say, okay, this might be something that can really help you. Second session, we might say, all right, these are the 3 goals that we both agree would be really beneficial. And then there might be a phone call a week later. And, if the answer is, I just can't find the motivation. It's a setting like that where I might say, you know what, maybe we shouldn't rush into this. And I might call again in a few weeks or check in a month, something like that, until there's a sense that we're really on the same page, that entering into this ketamine process is not just another trial of an antidepressant for me. It's really an opportunity to make a lot of change if possible.
And then you go on to what I might call the induction. Is that a proper word, session?
Sure, yeah, the acute treatment.
What is the setting like, and what is the supervision or accompaniment like in that session?
We use a setting that would make a psychedelic therapist's head spin a little bit because it is quite medical. And that's intentional because, this is a medical procedure and people come to us also with a medical way of seeing the world usually. At the same time, compared to most psychiatric settings, it's very pleasant. We have a carpet, we have plants, in addition to the IV pump, in addition to the blood pressure machine and the heart rate monitor. And yeah, that first session involves introducing people to the space. It involves usually giving them blindfolds that we ask them to bring back at every session that become a little bit like a transition object. And then it either involves, in our model, carefully selected music or guided one-on-one or two-on-one mindfulness exercises throughout the infusion.
Do you mean that they're using an app to guide the mindfulness?
No, it means that we always make sure there's at least one person in the room with them. There might be two, depending on the team I have with me or my colleagues running sessions. We might have a therapist and a learner. We might have a psychiatrist and a resident. We might have a nurse and a social worker. That really varies. It really is just important to have people that are comfortable guiding people through the ketamine experience.
So they're there, if I understand right, their purpose is to help the patient feel safe about observing and being aware of their experience.
So yes, and back to this idea that ketamine looks very different depending on the words and the context. If you provide people with blindfolds and especially with music, they will have almost guaranteed powerful stuff come up. And it might simply be fear. It might be panic. I mean, in all the trials, there are usually a rate of 1% to 5% of people dropping out due to anxiety or panic. And that's not even with blindfolds, which really magnifies people's kind of internal experience. Essentially, in this model, we are creating the context for powerful experiences to happen, even if the dose is the same as the regular biomedical model. And inevitably, these experiences do happen. And so the guiding involves, in general, as you said, cultivating curiosity. There's this idea from the psychedelic paradigm that the central message that people need to hear over and over again is to let go and be open. Another element of the guiding is just to encourage people to not try to understand or draw conclusions, sort of what I mentioned regarding the example of the nurse, the person who thought maybe they should become a nurse. I mean, that's the kind of idea we would encourage people to look at more metaphorically than literally. And in general, to just sort of make sure people feel like they're supported and that this process for them is meaningful.
Do they wear headphones?
So that's where we've done something different because we conducted an RCT of 32 patients who were randomized to receive either music or no music throughout their 6 ketamine doses. And these results we're still analyzing and writing them up. But in a nutshell, what we found is that in the music group who were receiving headphones and with music also playing in the room, they had all sorts of powerful, often synesthetic or heavily visual experiences with music. And in the group that didn't receive music, it's a very different kind of vibe. It actually looks a lot more like a guided meditation because they want to interact with the person in the room much, much more. When you have blindfolds and headphones on, the only way to really interact is to rip off your headphones because you dislike what's happening. Or, sometimes people do narrate a little bit what they're experiencing to the person sitting in the room so that they can debrief later. But yeah, normally in the music model, we provide 50 to 55 minutes of music and people are encouraged mostly to kind of go into their own experience and then debrief afterward.
How do you choose the music?
We have 8 or 9 playlists that we've very carefully created over the last few years. In the psychedelic paradigm, music is essential. Music is probably the cornerstone that separates the psychedelic from the more biomedical model of ketamine, for example, but also psilocybin, LSD, MDMA. The idea with music is that the goal is to kind of create, in general, a little bit of an arc. So it begins with calming songs that ease people into their environment, and then gradually builds in intensity for maybe the middle 20 minutes, and then returns to calming to kind of bring people back to reality.
How long is the whole experience?
So the whole experience, the music playlist for us are 50 or 55 minutes. Generally, when you start a playlist, right when you start the 40-minute infusion pump, what most people experience is very little, actually. They notice very little changes for about 10 minutes. And then it builds in intensity to the 40-minute mark, as you'd expect with the plasma concentration increasing. And then usually it's about another 10 or 20 minutes before they're ready to talk about what they've been experiencing. And then after all that, maybe they're back to their baseline about 30 or 40 minutes after the infusion ended.
Are you able to share the playlist in any way? Are they on Spotify already?
They are on Spotify, yeah. You might be able to find it as Montreal Ketamine Clinic. One word, Montreal Ketamine Clinic.
I was surprised, as I thought, like in sleep research, they often have the patient choose the music. How does that fit in the patient choice?
That is a wonderful question, because we started with the idea that we would do music in our ketamine work a lot like they've done in psilocybin studies, where there is a set playlist that everybody gets. And even in the psilocybin world, there's even sometimes this idea that like this is the one playlist, this is the best playlist for this work. And we might have been biased by that idea, because in the end what we realized is indeed there is a whole range of responses to different music. And one of the best things to do as you progress in this work with a given patient is to invite them to bring their own music in.
And I take it you have several sessions here, so that's why you have different playlists?
Yeah, we often will, choosing the music is, in my mind, akin to choosing sort of the session activities of psychotherapy, And so I think it's important to find the right playlist for a given patient in the right moment. So we have playlists that are heavily classical music and very evocative. But some people hate classical music. And we have playlists that are more jazz, again, very evocative and very powerful for some people, but other people hate jazz. And so we'll choose a music playlist that fits, the therapeutic intent and also a patient's preferences at each session.
You let them pick one of the playlists and then you let them develop their own playlist, is what you're saying.
Exactly. We let them pick a playlist, and in general, we ask them to consider bringing in their own music, even if it's one or two songs that we incorporate into one of our playlists. And, just to say the world of music and psychedelics is rapidly expanding. There's whole conferences on how to choose music for psychedelic therapy. And there are certain rules, like that music shouldn't have understandable lyrics. So if you're an English speaker, that shouldn't have English lyrics. The music should be unfamiliar, but that's obviously not what we do, as I'm talking about. So there's all these rules that I think actually are less important than involving patients with depression in their own care.
Do people bring in other stuff? Teddy bears, Bibles? Is there other things that help?
Patients often bring in a blanket, which I think is great because we only have very scratchy hospital blankets. But beyond that, no, I actually am not sure. I don't think people have ever brought in a Bible, for example.
Greenway is an assistant professor of psychiatry at McGill University and director of the Ketamine-assisted therapy program at Jewish General Hospital in Montreal, Canada. You can find his full review in our online edition for June 2024. The Carlat podcast team is now on video. Find monthly episodes of Carlat Psychiatry News on the Carlat YouTube channel or under webinars on the Carlat page.
Join us next week for Ketamine-assisted therapy with Dr. Greenway.
Thanks for watching. Hit subscribe if you enjoyed this content. And to earn CMEs for listening, head on over to thecarlatreport.com/podcast.